So today we are going to see about the lower extremity mobilization starting from the hip joint. So first range of motion that will be restricted and we want to increase will be flexion and internal rotation, that we will increase by the posterior glide. So for the example purpose, left limb is not affected. This is the left limb of the patient, right limb is affected, and I'll ask the patient to keep the hip and knee into flexed position. Yes, once the patient has kept the hip and knee into flexed position, I'll support the other limb off the ground, yes, so that the femur is completely relaxed. When the femur is relaxed completely, yes, I'll try to palpate the hip bone, acetabular cavity and greater trochanter of the femur. Once I am able to find the head of the femur, I'll try to check for the joint play. I'll check for the joint play. It is completely normal. I'll have to compare it to the opposite side to say it is normal. And then I can provide the mobilization depending on what is my aim, to decrease the pain or increase the range of motion. So this is grade 1, initial small amplitude. Grade 2, large amplitude, moving up to the tissue resistance, only moving up to the tissue resistance. Yes. Grade 3, increasing the range, moving it down up to the tissue resistance, again large amplitude, oscillatory technique. You can see both my arms are completely into extension, so the force that I am providing is through my body and not through just my shoulders. And grade 4, moving into the tissue resistance and small amplitude oscillatory mobilization. Yes, this is specifically for increasing flexion and increasing the rotation, internal rotation. Relax. We'll ask the patient to relax. So this was the first glide, that is the posterior glide of the hip joint. Second glide for which we are going to perform for the hip region is the anterior glide, that is to increase the extension and external rotation. So again, for the example purpose, now we are taking the left side as affected side, right side is normal. Relax, relax, relax. Okay. So the patient will be again outside the plinth because we want to mobilize the hip joint. For that, we need the patient out of the plinth so that we can mobilize it very easily, and the couch or the surface on which the patient is lying will not hamper our joint play. So again, other limb will be completely relaxed. We are not going to do anything with that. Here we have to, there are two options we can perform. First is to have a belt. Now it is not feasible to have a mulligan belt with everyone. So right now I am just demonstrating if you do not have a belt and how will you perform. So I will bend the knee first and then hold the hip into resting position of the hip joint. Abduction of 30 degree, slight amount of flexion 30 degree and slight amount of rotation. Here I am able to palpate again the head of the femur. For that, I am moving again with my elbow extended. All the grades of mobilization can be easily applied. Yes. So here you are seeing how am I supporting the whole part. The limb is supported completely and then I am mobilizing. It will be difficult if the patient is heavy or hefty and if the height of the therapist is low. Yes. So in those conditions you need to have a stepper, or you can provide a mulligan belt also. Yes, so again all the grades of mobilization can be easily given. Relax. Alternatively, you can also provide both the glides, anterior and posterior, in the sideline position also. The next glide that we are going to talk about is specific to tibiofemoral joint. So for that joint we want to have, that is the knee complex, we want to start for the demonstration purposes, this side, that is the right side of the patient, is affected side. Here knee flexion is affected, so for knee flexion I am going to provide posterior glide. So first of all, the therapist will sit directly over the foot, near the foot of an individual. So this is the foot region. I will be sitting right here. Yes, I will not be compressing. Relax, relax. I will not be compressing the part. Yes, I will not sit on the foot. I will sit near the foot so that I am stabilizing the part. The tibia is stabilized. That is the main aim. Now here I will move my hands just around the tibia. Yes, my thumbs will be on the anterior aspect and I will try to pull the knee outside, that is towards me. That will be anterior glide. Yes, and if I want to provide posterior glide, I will push the tibia, yes, in the direction of the femur, so that will be posteriorly gliding over the femur. Yes, so here it will be posteriorly gliding. So right now for knee flexion I will be providing posterior glide. So again same thing can be provided. I can feel and move the part, compare it to the opposite side, see if the joint play is decreased or not. Once I have confirmed the joint play is decreased, I will apply grade 3 and 4 to increase the range of motion, and grade 1 and 2 to compensate for the pain that the patient is feeling. Again, all the grades of mobilization can easily be demonstrated on this condition. So for example, if I want to demonstrate grade 2, that is large amplitude, so I am pushing this posteriorly and large amplitude up to the tissue resistance. Grade 3, if I want to provide, that will be again large amplitude moving into the tissue resistance. Here I am not feeling any tissue resistance because this is a normal individual. Again, even if my arms are flexed, my elbows are flexed, you can see I am not providing just by this movement. I am as a whole moving myself. Yes, so my whole body weight is providing the mobilization. Yes, and grade 4, yes, moving into the tissue resistance, that is the end range, and then you are starting to provide the mobilization force. So that is about the posterior glide. Similarly, for the anterior glide, you will have to provide the same traction that you are providing, but in the opposite direction. So the grasp will be the same, and you can move the part towards you anteriorly. Yes, so the tibia will glide anteriorly over the femur, and then you can provide again the glides that you want to, depending on the comparing it to the joint play of the opposite side. Similarly, it can be demonstrated for both the glides. Coming to the next joint of the knee complex itself, that is the patellofemoral joint. So here we are going to see the movements of the patella. Yes, first of all, the normal movements of patella. Patella can move distally, can move proximally, can move medially, and can move laterally. Yes, so these are the 4 motions that you are going to check. So whatever motions I did, say for example I am moving the patella downwards, that is in the distal direction, that will be checked for joint play of the flexion, knee flexion. Now this also helps proximal for knee extension. Medial and lateral rotation or medial or lateral glide of the patella specifically will be used to maintain the normal necessary motion of the patella over the femur. So that will again help the patient achieve normal flexion and extension. Opposite limb can be completely relaxed. Now what should I do? I will be standing right on that side, but here for the demonstration purpose, I am first demonstrating the proximal glide. So I am grasping with my first web space the patella. Yes, I have palpated the patella, it is very easy to palpate, and trying to move the part upwards. Yes, I am moving the patella upwards, and again all the glides are possible. So this is first glide first. So initial range, short amplitude. Glide 2, if I want to provide large amplitude in the initial range only, not reaching the tissue resistance. Glide 3, so again large amplitude moving into the tissue resistance. Yes, so again you can see it is large amplitude. And glide 4, moving at the end range up to the tissue resistance and moving in, again small amplitude. So this will be small amplitude towards the end range. Similarly, for the distal glide, I will be standing on this side, and again with the first web space I will be grasping it, moving it downwards, relax. If the patient is not relaxed, you will harm the patient as we had described. It is utmost important the patient should be relaxed. Moving it downwards, and again we can glide. All the 4 glides can be demonstrated easily over the distal aspect. Similarly, if I want to move the patella laterally, my hand will be on the medial aspect, and I will try to move the patella laterally. If I want to move the patella medially, my hand should be keeping the force on from the lateral aspect. So I can use both my hands. With the thumb itself, I can move the patella medially. Yes. For the medial aspect, you will not be able to see in the video. For the lateral aspect, you will be able to recognize the movement. Yes, so this is for the patellofemoral joint. For the tibiofibular joint, proximal part is not important, only used for the dislocation when it is dislocated, and as we had described in the theory aspect, we are not concerned with it. So we will directly move to the distal tibiofibular joint. Moving forward to tibulofibular joint, as we described, the proximal part is not that important. For the distal part it is important because 2 important motions that are happening, because here articulation, the ankle mortise is formed by the tibia and the fibula in which the talus will articulate. So here the first motion that is possible is dorsiflexion and second is plantar flexion. Yes. So for these 2 motions specifically, ask the patient to completely relax and the limb will be kept slightly upwards so as to we can move the fibula into the posterior and anterior direction. Now posterior direction, if you are moving, it will increase the dorsiflexion according to Corker-Corvex rule, and if you are moving into the anterior direction, it will increase the plantar flexion. Yes. So how you will try to hold and stabilize this part. Again with this part, other hand, you will try to grasp the malleoli, moving the distal aspect of the malleoli into the downward direction. Yes. So again I am providing force with my elbow extended with my whole body weight. Yes, again all the grades of mobilization you can easily perform. This was the posterior glide. I can also perform the anterior glide. So for anterior glide, I will have to keep the arm in such a way that I am supporting like this way. Yes, behind the malleoli, and try to push it upwards, outwards. Yes, again stabilizing the opposite side, medial malleoli, and moving it upwards as much as possible. Again all the grades of mobilization can be performed. Again, first of all you need to check for the opposite side, see for if there is any decrease in the joint play, then only you are going to perform mobilization. Yes. Also talocrural joint can be demonstrated in the same position. Talocrural joint again formed by the ankle mortise and the talus. Here we were just mentioning about the tibiofibular. So tibia and fibula were articulating. Now this mortise that is formed, in that talus will be articulating. So you will stabilize here, the talus will be mobilized, and you will be stabilizing the both malleoli, tibia and the fibula. Again same direction, if I am moving it posteriorly, it will increase the dorsiflexion range of motion. So I have just palpated both the malleoli. With both the malleoli stable, I am moving the talus into the posterior direction. I am pushing it downwards. Yes, so that is the posterior glide of the talocrural joint. Similarly, I can perform in the prone lying position for the anterior glide, or I can keep my hand slightly posteriorly to the malleoli, palpate the talus and move the part anteriorly, that is upwards. Yes, that is also possible. Again my elbows are completely extended, my whole body weight is being provided the mobilization force. Yes, so both these ranges can be increased, dorsiflexion and plantar flexion, with two joints, tibiofibular as well as the talocrural. Yes, talocrural, that is the mortise articulating with the talus. Moving to the last portion of the foot, subtalar joint, specifically subtalar, as the name suggests, below the talus bone. Yes, so talus here articulates. First of all, you need to know about the concave convex rule. So here it was ankle mortise that was concave, talus was convex. Downwards, concave will be the talus and calcaneum will be convex. Yes, so the direction glide that you are applying will be opposite for increasing the inversion, eversion and plantar flexion, dorsiflexion. So here you will stabilize the talus in the posterior direction. You are going to stabilize the talus and try to mobilize the calcaneum. So here you are grasping the calcaneum ball of the foot and mobilizing it into the direction. Yes, and opposite also can be done. The main thing, you need to stabilize the talus as much as possible. That is why the patient is taken prone line and the foot should be outside the treatment table, so as you can effectively grasp the talus and mobilize the calcaneum. Okay. Moving forward to other joints, subtalar joint, intertalar joints, and also the MTP joints, metatarsophalangeal and IP joints. Yes, interphalangeal joints also. For all of them, the same thing will be there. The distal surface will be concave, so the glides will always be in the same direction. So if you want to increase plantar flexion, say for example at the MTP joint, you will grasp the MTP joint. I am just showing you for the demonstration purpose. You will just grasp it here and move it into the plantar aspect. So that will again increase the plantar flexion range of motion, same side. Yes, because the distal surface is concave. And if you want to increase the opposite side, you will just grasp it. Dorsiflexion, if you want to increase, move the foot, move the metatarsals into the same direction. Yes, into the, and this will directly grasp. Here you no need to provide it in the standing position because these joints are very small. Relax. These joints are very small, they require very small amount of motion. Similarly, as we talked about the fingers. Yes, so even if the book, if you refer, it is written same thing, that if you provide the fingers, it is no need to provide with complete body weight. You can provide it with specific range of motion. with specific muscles only, may that be with upper limb, shoulder, or even with elbow, because these muscles are smaller, these joints are smaller, and they provide only accessory motions to pronation and supination ranges of motion for the foot.